What are the top three reasons for homelessness in Canada? What is the one thing that most people misunderstand about addiction?
So, I mean, marijuana is very tricky for sure. I wish we had an age level that was a bit higher up than 18.
Okay.
We are seeing an increased number of mental health concerns related to marijuana in the communities. We are seeing a higher number of youth who are consuming marijuana. So you're right. There is this concept that we're enabling drug use by providing harm reduction services such as a supervised consumption site, providing sterile needles, providing naloxone kits, which is the reversal agent for an overdose. And the truth is, we're not enabling at all. People are going to be doing this anyway. We're just making it safer. Unfortunately, it's not. Alcohol can be one of the most dangerous drugs out there. In fact, it is one of the most dangerous drugs out there. It costs our health system more than anything else.
But what are the gaps that you see between the policymakers and what is actually needed?
I think the biggest thing that people are looking at Alberta around is the Compassion Intervention Act. So this is forced treatment of addiction, mandatory treatment of addiction against people's will. So involuntary treatment. So this is something that's happening, that will be happening in Alberta very soon.
Mm-hmm.
So Rat Park is this story. It was a study done at Simon Fraser University in Vancouver, and in the 70s. And what they did was they put a rat in a box, and the box had two drips. It had a water drip and a heroin drip. And what they found was that the rat used the heroin drip until it died. Every rat that they put in these boxes used the heroin drip until they died. So right now, for example, with the Norris line, we've had over close to 30,000 phone calls right now over the years. And we've had over, I think, close to 300 overdose events or deaths that were prevented from it.
Have you ever wondered what it really takes to create change in healthcare, not just for the patients, but for the entire communities? Hello and welcome back to the Neha Jog podcast. Today's guest, Dr. Monty Ghosh, is a physician, researcher, and change maker working on the front lines of addiction medicine, homelessness, and public health. Through his work, he's been shaping programs that support some of the most vulnerable population across Alberta and beyond, while also teaching the next generation of healthcare leaders. In this episode, we talk about the challenges and rewards of working in the complex healthcare systems, what it takes to humanize medicine, and how small changes can create a ripple effect of impact. This episode is for anyone who cares about healthcare, social impact, or simply wants to understand how compassion and innovation can come together to change lives. So make sure to watch this episode till the end, and you will walk away with insights that might just change how you see the future of healthcare. And if you haven't yet subscribed to the channel, please do so, as it really helps me bring more such inspiring conversations your way. So without any further ado, let's dive right in with Dr. Monty Ghosh. So welcome to today's episode, Monty.
Thanks for having me here. Appreciate it.
How was your day? How have you been?
It was a busy day today already. Yeah, just left work, got here.
Oh, okay.
Yeah, so this is my relaxing time.
I hope it is. So what got you into medicine?
Medicine for myself was a long journey, I would say.
Yeah.
But the real reason I went into medicine was because I would say initially because I love to travel.
Mhm.
And I would travel all over, and learning about what groups like Doctors Without Borders or the Red Cross would do was something I was very keenly interested in. And that's what initially got me into the medical field. That was my passion, to go serve populations worldwide. Didn't pan out that way completely, but that's really what drove me into the field.
But whatever you do is such a niche area. So how would you explain to people in a very brief manner, like what you do?
Absolutely. So essentially, I work on what's called health equity. So we know that there's certain populations within our city, our province, our country, who don't have access to appropriate healthcare needs that's tailored towards their specific needs. It's sometimes hard to access healthcare for them. Sometimes they've been mistreated in the past, so it's difficult for them to engage with health. So my purpose in my work is really centered around making health equity available for people who are marginalized, whether that's people experiencing homelessness, people with severe mental health concerns, people who are in corrections, people who are living impoverished in some means or forms. So that's kind of who I work with.
But what was your turning point? And you made this decision of making this your full time career rather than the traditional medicine that you could have gone for.
It was from a mentor, actually.
Okay.
So initially, when I graduated from internal medicine at the U of A in Edmonton, I came to Calgary to be closer to my parents. My father was very sick at the time. He was going through chemotherapy. And so I moved here to be closer to him and to help him out with his health needs. My goal was to eventually go back to do Doctors Without Borders, be overseas. But it was hard because my father needed me here in the city. So I had met an individual named Martin Labrie who just recently retired, and he's a huge mentor to me. And talking to him, uh, I was telling him how I wanted to go back overseas, but it was difficult because I was trying to stay in the city for my father. And his advice to me was that I just needed to look around me. He's like, if you just look around you, you can see that there's still lots and lots of health inequity that exists right here in the city, and that you don't necessarily need to travel far and wide to provide support for those who need help the most. You don't need to go overseas to help those who are most vulnerable. You just have to look around you, and you can find them right here. And so that's what I did. I began to focus my career on health equity within the city of Calgary, and then more broadly, Alberta.
Okay, so let's talk about addiction. What is the one thing that most people misunderstand about addiction?
I think what people think about addiction when they think about addiction is that they think it's a personal choice, and that it's a behavioral issue that they decide to do. I think it's a moral failing at times as well, and I think that's the biggest thing that people have a misconception on addiction, is that it's not actually a moral failing. It's not a behavioral choice. It is something that they're compulsed to do, that they're impulse to do, because essentially what addiction does is it takes over the neural pathways that are involved in our primal senses, in our primal sense for survival. Um, so what do I mean by that is that we eat food to survive. We engage in sexual activity to sort of keep the species alive. That is what addiction does. It takes over those systems, those basic systems, those basic dopamine pathways, if you may, pleasure pathways, to the point that we can't control it anymore. And so addiction, again, is not necessarily a behavioral issue. It's definitely not a moral issue. It's a biological disease pathway, much like any other disease that exists out there, whether it's diabetes, high blood pressure, uh, liver cirrhosis, kidney disease, falls under the same pathway.
Right. But like when we think about homelessness, like common people, what they picture is tents, people living on the streets, but things are beyond that. That's not the whole picture. Is that
Absolutely.
true?
It absolutely is. It's not just them living on the streets. There's a lot of trauma in the past that they've experienced as well. And I think that's something else that people need to recognize, is that people who are living on the streets aren't necessarily living there out of choice. There's a lot of complexities that got them there in the first place. Much of this stems to childhood trauma, so what we call adverse childhood experiences. This can include emotional, physical, or sexual trauma as a child, physical, emotional neglect. It can include having a parent incarcerated, a parent with mental health concerns, divorce. So trauma really does impact where we are later on in life and whether or not we have poor outcomes with our health. And this can include homelessness, but it can also include brain injury, mental health concerns, lack of opportunities or access to opportunities such as housing, income support, education. All of this kind of stems to trauma, and even broader than that, societal impacts as well. So they've looked at adverse childhood experiences, and they've gone even beyond that to recognize that there's social determinants of health that have impacted the wellness of individuals right from the get-go, from an early age. So many children, for example, that are born in Canada don't have access to proper nutrition and food. They're experiencing racism or discrimination in where they're at. They often have inability to access educational resources because of where they live in the neighborhood that they live in. There's no after school programs, for example, that are there to support them. They don't have proper parent support because their parents are both working because of their low income status. And we see this a lot with immigrants, for example, as well. We have immigrants who work in who are constantly working to provide support for their families. The kids are often left alone. That's seen as neglect in some respects. So all of this can lead to poor health outcomes later on in life. So while we do have adverse childhood experiences, the counterbalance to that is what I would call essentially, um, and all of a sudden the term just escapes me right now. But I want people to know that just because they have adverse childhood experiences, that they're not all broken.
Mhm.
There's resiliency factors, and that's the term I was trying to think of right now. There's
Okay.
resiliency factors that exist as well. And these resiliency factors can help bolster a person to make them the best they could be later on in life. And that these resiliency factors include a sense of community, having proper social supports around, um, having being loved in general. These are things that can hopefully help someone be the best they can be later on in life. And so a sense of community doesn't necessarily mean to be the community that's around you immediately, like in your neighborhood. It can be a sense of cultural community as well.
Right.
And so I know from the South Asian community, for example, that we often gather around each other, support each other. And it's those resiliency factors that really help an individual be the best they can be.
Okay. What are the top three reasons for homelessness in Canada?
Substance use and addiction is definitely number one. Mental health concerns for sure is number two. And I'm going to go out on a limb here and say that number three is brain injury or head
Okay.
trauma. So we know that a lot of people who are experiencing homelessness, especially chronic homelessness, are experiencing homelessness due to traumatic brain injuries of some sort or nature. Whether this is physical trauma, whether this is trauma from overdoses, whether this is also potentially baseline cognitive concerns from things such as fetal alcohol syndrome, for example, that they're born with. These can all impact the wellness of someone, impact their ability to be functioning in day-to-day life, and can lead them to the path of homelessness.
The first one you said is substance abuse. Is there any age that you see majorly, like kids? Are there like youth who start substance abuse and, just go overboard with it? Or is there like mid-age crisis people who, because of maybe personal relations or divorce or something, get into this and.
So addiction is very, very complicated. And there's no set age in which someone can become addicted to something or the other. We do know that there's several factors that come into play. So genetics comes into play. So if you've got a family member who's had a substance use issue, you're at a higher likelihood of having a substance use issue as well. You know that mental health comes into play as well. So if someone has anxiety, depression, they can sometimes turn to substances to mitigate those feelings, those issues. Same with ADHD. If you've got ADHD, some people turn to stimulants to manage that as well. So there's mental health that comes into play too. The other factor that comes into play is definitely exposure to substances. We know that when you're younger, your frontal lobe, which helps for impulse control, helps stop you from using substances, isn't as well developed. And so if you are using substances at a very young age, there's a higher likelihood of you having further addiction later on down the line, but also there's also concern that your frontal lobe will not be as well developed as someone who hasn't used substances. And if that frontal lobe isn't well developed, you're at a higher likelihood of having difficulties dealing with impulses and more difficulties dealing with getting off of substances later on. And so, yeah, those are kind of how things interplay. It's much more complex than just that.
Right.
But that's kind of a basis.
Okay. Do you think when it's not substance abuse, like obviously that is different, but when marijuana was legalized here in Canada, do you see a difference of the stats of how people were affected by it before when it was illegal and after it was legalized? What is
Yeah.
your opinion on that?
So, I mean, marijuana is very tricky for sure. I wish we had an age level that was a bit higher up than 18.
Okay.
We are seeing an increased number of mental health concerns related to marijuana in the communities. We are seeing a higher number of youth who are consuming marijuana. And youth is anyone from the age of below the age of 24.
Okay.
So it is going to be a problem. I think we're going to see more and more of it in the future. Whereas alcohol causes a lot of physical problems on top of mental health problems, marijuana can cause a whole litany of mental health issues and concerns. It's been linked to schizoaffective disorder. It's been linked to anxiety, depression as well. So I think we're definitely worried about an increased number of adverse events and effects associated with marijuana in our population, and we definitely are seeing a higher prevalence of it overall.
So that wasn't a great decision by the government to
To
legalize it.
legalize marijuana, I think it was good to decriminalize it for sure. Legalizing it is okay, provided we have a bit more structure around regulation. So I think putting caps on THC concentration, for example, within marijuana is important. I think having limits in terms of how much people can consume would be important. Increasing the age limit to 21 would be a good thing to do instead of 18 here in Alberta, maybe even 25. I don't necessarily think it's a bad thing. I just think we need to have a bit more stricter regulation over it.
But how much of this addiction would you say is biological and environmental?
It's hard to say. It definitely is both nature and nurture. How much one weighs more than the other in terms of causing someone to go into the path of addiction is hard to say.
Okay.
It varies from person to person. Again, and it also depends on these resiliency factors that I spoke about. If someone has the right environment around them and resiliency around them, but a high genetic predisposition to an addiction, they may be still okay. And so it's hard to say.
But you did mention that poverty and low household income does play a role into all these things.
Absolutely, poverty can play a role into this. It's more about exposure to opportunities, but there's other factors involved as well, such as low education, discrimination, lack of food access. All of these things can come into play to further make adverse childhood experiences worse for individuals, which can then therefore lead to substance use. So these are just a broader. So when we look at adverse childhood experiences, there's actual experiences, but there's also the broader societal impacts and experiences that a person can have. That's also sort of a more extended version of the adverse childhood experiences that we see. And that's where I talk about discrimination, poverty, food access, etc., lack of access to health supports and needs,
Right.
that kind of stuff.
While I was researching about this topic, I also came across this term harm reduction. What is it?
Harm reduction is a set of policies, if you may, ideas, policies, programs that are very much grounded on a realistic idea of what's going to happen with an individual. It comes from a lens of compassion. And what I mean by that is that we do know that for some people, they cannot stop using drugs.
Okay.
But instead of condemning them, instead of not providing any resources for them, we focus on providing still supports for them, like providing, I should say appropriate supports for them within understanding and knowledge that they're not going to stop. So this is improving their quality of life by getting them access to food, housing, income support. It can mean making sure that they are getting clean and sterile supplies so that they don't pass or get HIV or Hep C from sharing supplies. It means making sure that they stay safe while they're using so that they don't overdose. So we do harm reduction on a regular basis, whether we know it or not. So for example, today I drove here to be part of this podcast and I wore a seatbelt. Driving is a very dangerous activity. We can get hurt while driving. We can get killed by driving. But to reduce the risk, I wore a seatbelt. I went biking not that long ago and I wore a helmet when I was biking. Biking can be a very dangerous activity, but with a helmet, you're okay. Did you get a chance to go on water anytime soon the last little while? Did you go rafting or were you on a boat?
Yeah.
Yeah. Did you wear a life jacket?
Yeah, for sure.
Yeah. That is harm reduction as well.
Okay.
So harm reduction is basically a philosophy in which you recognize that you can't stop people from doing harmful activities, but you try to reduce the risk of hurt and damage, but also improve potentially their quality of life as well down the line. So that's kind of what I do. That's another focus of mine in my work.
This is a little controversial. If you ask common people, they would be like, I don't want my tax money to go into supporting this kind of activities. Why would you want to encourage them? Maybe. What is your answer to that?
So you're right. There is this concept that we're enabling drug use by providing harm reduction services such as a supervised consumption site, providing sterile needles, providing naloxone kits, which is the reversal agent for an overdose. And the truth is we're not enabling at all. People are going to be doing this anyway. We're just making it safer. We're just making sure that we're reducing the risk of, say, disease spread, mortality, poor outcomes with this population group, and then we're making their quality of life the best they can be. health is not an absolute thing. We don't try to cure everyone from everything, right? We can't cure diabetes. We can't cure high blood pressure already. There is no cure for that. And for some substance users, they can't stop. And substance use is a lifelong process. So for those who have really, really horrible addiction, it's this understanding that the reality for some individuals may mean that they can't stop, but we still provide support and help for them as best we can, because no one should be denied access to health services. And this really is a health service. Harm reduction is really providing necessary health supports for this population group. And it can sometimes also lead to recovery as well. So the flip side of harm reduction is recovery. And some of the best ways to get someone to recovery is through harm reduction. When people start to engage with health supports through harm reduction, they often feel more comfortable in dealing with health supports. They form relationships with the nurses who are providing them with these health supports. That often encourages them to get into treatment, getting onto medications that can help deal with their addiction, getting them into a bed-based treatment program, getting them off the streets, getting them back into work. So harm reduction is often a gateway into more larger supports that can help them get into the path of recovery.
I think you nailed it, because that's what my follow-up question would have been. Like, with harm reduction, do you also, try and provide other support like rehabilitation, something? But
That's exactly it.
you
It is a
answered it.
pathway for that support.
You have built many other innovative programs like home-based detox and virtual supervised consumption. Virtual supervised consumption sounds similar to harm reduction, is
Mhm.
it?
It definitely is, absolutely. So it
Okay.
is a harm reduction strategy. So right now, within our country, anywhere from 60 to 80% of the population who is dying from a drug overdose or a drug poisoning event is dying while they're using alone by themselves, typically in their own homes or at a hotel. And the difficulty with physical supervised consumption sites is that it's not always available for everyone. The what we call the therapeutic radius around these supervised consumption sites is often about 1 kilometer outside of it. And so not everyone can access these sites. Some people don't want to access these sites because of stigma. Some live out in the burbs, out in the suburbs, and cannot access these sites. So the harm reduction service, NORS, the National Overdose Response Service, is really a response to the needs of these particular individuals. And so the way it works is it's a phone line. So if you're going to be using drugs by yourself, you call this phone line and you'll be dispatched through to a person of lived experience who has experience using substances, who will stay on the phone line with you. And you're asked to unlock your front door, turn on your porch lights. You have to provide your address, of course, as well. And you can use your substance. And if at any point in time you have an overdose event, the person on the other line, because they're with you on the phone call, can dispatch EMS services to your home to resuscitate you. They can also enact a personalized response as well. So say you're at a harm reduction housing facility and you're using a loan, but you have receptionists downstairs. They can contact the receptionist instead to reverse your overdose with an naloxone. They can call a family member nearby who can help reverse your overdose. So there's multiple different things that we can do to help support this population who are using alone, and NORS is one of those things that can be done and used.
So this is a facility they are living in, or is this their own house?
Their own house. It can
Their
be anywhere.
own house.
Yeah. You just have to have access to a phone.
Okay. So usually, when you think about a person who's doing substance abuse, one would think they are not in their senses to call someone and tell that, okay, I'm starting my, okay, I'm falling short of words here, but doing drugs
Mhm.
or taking injectables right now, are they in their senses? Are they like living their normal life?
Absolutely. Yeah. For the
Okay.
most part. So like sometimes they can go into psychosis or they can get drowsy. But usually before they enter that state, before they ingest the substance, they're
Mhm.
using these supervised consumption sites or they're calling us. And sometimes even while they're using their substance simultaneously, they're calling us as well. And that's totally fine. But they're definitely, for the most part, in their senses while they're calling us. And because they're in their senses, that's why they're calling us.
Right. Okay. This is good to know. Like,
Mhm.
they're consciously doing this. It's a
Yeah.
choice.
It's a choice and it's for their own personal safety.
But all these programs that you do, if scaled properly, do you see impact of this program? How positive is it?
Absolutely. So, like, I mean, right now, for example, with the Norris line, we've had over close to 30,000 phone calls right now over the years. And we've had over, I think, close to 300 overdose events or deaths that were prevented from it.
This is Alberta,
This
Calgary,
is Canada
Canada.
wide.
Canada wide. Okay.
Yeah. So we're doing well with the program. We're monitoring stats. We've had 0 deaths on the phone line as of yet. We've had only 5 or 6 false call outs with EMS. So the line is going well. It's functioning well. It's making an impact. Now, it's not a substitute for physical supervised consumption sites. Physical supervised consumption sites are definitely crucial as well. They serve a different population, a different niche. We need both. Unfortunately, right now, whether it's Ontario or Alberta, there is an attack on physical supervised consumption services, and they're trying to shut these services down.
Who?
The government.
Why?
And that's a good question. They feel like it's disrupting communities. They're afraid of crime rates. They don't like the attention that it's attracting. They feel like it's enabling drug use. And the truth is it's not. It's not going to get rid of the problem. If they're worried about public drug consumption, if they're worried about people experiencing homelessness running around, if they're worried about violence associated with methamphetamine use, for example, that it's not going to change by shutting these sites down. These sites are strategically placed in spaces where this population already exists, where they already habitate, where they already live, essentially.
Right.
And by removing them is not going to change that. It's not going to change where these people already are. They're not going to move away all of a sudden. They're going to stay exactly where they are, except you'll be seeing more public drug use, more overdose rates and deaths, sadly. And it's a misconception to think that by shutting down these sites that you're going to make things better.
Yeah, you actually answered my question. I was going to ask you, where are these sites placed? Because if it's placed within the communities, then I understand the concerns. But
Mhm.
as you mentioned, if they're strategically placed where this population already exists, then
Exactly. Like they should be placed close to shelters, which most of them are.
right.
High density areas where there's a lot of people experiencing homelessness, but a lot of people experiencing substance use as well. So that's where these sites are usually placed. They're expensive to run to a certain extent, but the benefits of them far outweigh the costs, and we do see that with some of the data as well. So it's a crucial piece to managing the substance use crisis.
How has your experience been working as a virtual supervised consumption and also home detox?
What has my personal experience been? So I'm more into the program implementation side of things
Okay.
and evaluation, but it's been great. I think we need the way that I function with, and a lot of my colleagues function as well, is that when we see that there's a gap in resources or gap in services, we try to address that gap by figuring out a solution. So, for example, we noticed that in Calgary that people would always go to Renfrew, for example, which is a detox facility or Alpha House, and often they would get rejected because there was just not enough capacity. What we do know from science, however, is that a good portion of the population who's trying to get detox can actually do detox at home. They don't necessarily need to be detoxed in a physical facility.
Sorry, can you also explain what detox
Oh yeah,
is?
absolutely. So when people are trying to come off of alcohol or cocaine, or
So
meth,
similar to rehabilitation.
ish. So it's before you can get into a bed-based rehab program, you have to stop using whatever you're using. And often if you do stop using whatever you're using, whether it's opioids or alcohol, more particularly opioids and alcohol, you can have withdrawal symptoms. And those withdrawal symptoms can be very severe. We see severe withdrawal symptoms with alcohol. We can see what's called delirium tremens, like shaking. We can see psychosis from delirium as well. We can see seizures happening too. With opioids, we see stomach cramps, people feeling a lot of pain, feeling cold, feverish, a lot of bad symptoms as well. And so people often cannot get off their substance because once they start to feel these withdrawal symptoms, they feel like they need to use the substance again to get rid of the withdrawal symptoms. And so having a space where they can go and be medically supervised while they detox is helpful and important. But not everyone has to actually go to a physical site to get detox. They can actually do it from home if they have the right supports available and if they're on the right medication. And that's what home detox is really about. It's by increasing our capacity to take care of detox issues within our own communities.
Okay. So even general population, people who are doing 9 to 5, and from the outside you might feel like they're living a normal life, but they would still be addicted to alcohol and trying to. Have you
Mhm.
seen
Absolutely.
such
We
people?
see high functioning substance users all the time.
Yeah.
Not everyone using substances is experiencing
Homelessness.
homelessness
Yeah.
or severe mental health concerns. In fact, about 20% of our population has an addiction, whether it's nicotine, whether it's gambling, whether it's a sex addiction, for example, alcohol, cannabis. A lot of people can be highly functioning and still have a substance use concern at the same time.
Yeah, that's what I was thinking about.
Mhm.
So, how does recovery for these people look like? Is it different from how people would imagine or how we see in the televisions or movies?
So recovery is different from every person. Recovery is very much a journey,
Hmm.
and the definition of recovery is very independent. Sorry, I should say it's dependent on the person themselves, what they see as recovery. So recovery for some people may mean reducing the overall amount of alcohol that they drink, so that they're not always intoxicated, that they're not always going blackout drunk, or even being drunk. Sometimes recovery for someone is being off of alcohol altogether. It's very tailored. It's very dependent on the person. It needs to be tailored towards the needs of the person, what their goals are. So yeah, for many people, recovery might mean abstinence, but that's not necessarily the case.
Like recently, there has been this buzz about homelessness and it was in news a lot. So, in your opinion, because you work so closely with homelessness and substance addiction, do you think Canada is moving forward with the homelessness issue or is it going backwards now?
I think the issue is not well understood,
Okay.
and it's far more complicated than we think it is. I think there's this concept that housing is the key to homelessness, and it is to a certain extent. But even if you do have enough housing out there, you will still have people who are experiencing homelessness, and they do not want to leave the streets. I think the way we need to look at homelessness is that it's a more of a brain injury issue, cognitive concern issue, capacity issue. And what I mean by that is that a lot of the population experiencing homelessness is traumatized, not only traumatized from adverse childhood experiences, but also they have physical brain injuries to them, that prevents them from cognitively functioning well in society. And so it leads to this place where they can't even enter a housing facility. They can't take care of themselves. They have behavioral issues. They can't learn. They can't retain information. They've got the cognition of a 6-year-old or 7-year-old. And so it's very, very complex. So I think we need to reframe our idea of what homelessness actually is. And for me, I think it's more of a health issue, an actual lack of housing issue.
So, is there a way out? Like, is there any way you would help these people get off the streets?
So I think about 30 to 50% of the population, the best way to get them the supports they need is to determine what their cognition level is, if they've got capacity, and provide them with a high intensity level of housing. So what I mean by that is that when we have patients, so for example, I work in Edmonton with a lot of patients who've had strokes or brain injuries from motor vehicle accidents or car accidents or whatever, right? So with that population, with their brain injury, they're properly taken care of in hospital. They have lots of supportive family who's there to see them. And then when they're ready, and if they're not rehabable, we get them to a facility, an institute, if you may, which is locked down, especially the behaviorally complex. And they stay there and they're supported, and that's great. When we look at their cognitive scores, and we use things in tools such as what's called the MoCA score, we often see that that their level of cognition, I should say, is very similar to those who are experiencing homelessness. So when I look at a homeless patient or a person experiencing homelessness, I do a cognition score on them. It's often very similar to these patients who have had brain injuries from various strokes, etc. But with that population, though, we don't actually take them into an intensive housing facility. We actually discharge them onto the streets. We kick them back out. We throw them back in the shelters. And that is not the place for them. They need to have the same adequate level of support as someone who is not experiencing homelessness and has a brain injury.
And
Unfortunately,
their
we don't.
families are They don't want to support them as well.
Usually not. Yeah, sometimes they don't have supportive families.
Okay. So their families basically leave them as well because.
Exactly. A lot of them are detached from their families. Their families don't know where they are or where they're at. They're also behaviorally complex. They can be very aggressive. They could be fighting people all the time. Yeah. So it's complicated.
Yeah, as a common man, even like many a times these thoughts come to me like mostly, obviously, these people are not born homeless.
Mm-hmm.
They probably would be living a normal life, went to school, worked a 9 to 5, or worked at great positions. But then life happened, something happened, tragedy, and right, they are here right now. And
Mm-hmm.
even like what I've heard, like mostly from people who don't know much about homelessness, is what their perspective is. Even if you want to help them, they'll not take help. They just want money to get their injectables or get back to their drug addictions. If you ask them, oh, I'll give you food, they don't want it. They don't need your help. They just want to be addicted and
Mm-hmm.
just be where they are. So how would you address, like, what is your answer to that?
So addiction, as I mentioned earlier, isn't necessarily a personal choice.
Mm.
And it's a situation of survival. So what addiction does is it hijacks the parts of the brain that are involved in survival. So when we eat food, as I said, when we have sex, we release dopamine. Dopamine is a neurotransmitter in our brain that's involved with pleasure, but it's also involved with keeping us alive as a person and as a species. And that is a part of the brain that drugs do hijack. So my sort of favorite analogy for this is what I call the desert island analogy. And so there's two parts of the brain that are involved with addiction. And I'm just trying to make this as simple as possible. We have our frontal lobe, which is our executive functioning part of our brain, the part of our brain that controls our impulses. There's also our mesolimbic system, which is a more deeper part of our brain, more primitive, that's involved with survival. And there's an interplay between those two parts of the brain. So for the most part, our frontal lobe is always working. Just because we see a candy, it doesn't mean that we quickly grab it and eat it. Our impulse might be to do that, but we have impulse control to tell us that we shouldn't be doing that. So if you are, say, stranded on a deserted island, and you're lacking fresh water, your frontal lobe is initially working. And so you'll draw a help sign in the sand. You'll maybe cut down trees to build a raft, try to find some coconuts to drink fresh water with. But as you get more and more thirsty, your frontal lobe turns off and your mesolimbic system, that primitive part of our brain, kicks in and keeps saying that you need water, water, water. It gets to the point that all you can think about is water. I don't know if you've ever experienced that before, where you're so thirsty that all you can think about is water, 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 water. Have you ever been there before?
But still, I've been very privileged to, I
Yeah,
to a point where you could control your thirst and you will find water at some
but
point.
say you didn't,
I haven't
right?
experienced
Fair
that.
enough. I've experienced it before. I was once biking out in the desert, in the Atacama Desert in Chile, and I ran out of water. And after an hour and a half, I was so thirsty and parched that all I could think about was water.
Wow.
Now, if someone was to come up to you and say, "Hey, here's a glass of water, but in exchange for the glass of water, you have to do bad things. Give me your home, give me your partner, your kids, for that glass of water," you would do all of that for that glass of water because you need the glass of water to survive. And as soon as you get that glass of water, your senses come back together. You're like, "What did I do?" I'll flip this around. So instead of water, have you ever been so hungry that all you can think about is food?
Yeah.
Yeah, you've been to that stage before,
Yeah.
and you could do anything that you would do a lot of things, that horrible things for food, potentially,
Yeah.
right? So that's the situation with substance users, is that their brain is hijacked by the substances, and if they don't get the substance, all they can think about is the substance. It hijacks their sense of survival. They need the drug to survive, and if they don't get the drug, they don't do well. They can go through withdrawal symptoms, which is very painful and agonizing. They can't focus and concentrate unless they use their drugs. And so when you see someone on the street and you're like, "Oh, they don't want food, they don't want water, they need the drug, they only want the drug," it's because it really hijacks their basic primal level of survivability.
Do you think it also goes to a level where if they don't get that drug, they might die?
It can potentially,
Yeah.
yeah. I mean, with alcohol and seizures, that can happen for sure.
With
But
alcohol.
absolutely, people die from alcohol withdrawal all the time. Yeah, it happens. It's a poor outcome because of seizures, because of delirium tremens. It can happen.
Like, alcohol seems like such a safe option. Like, people drink like nobody's business. It's just alcohol, right? I'm not like doing opioids or cocaine, or it's just alcohol.
Mhm.
Like I'm talking in very local, general terms. People around me, every age group will drink alcohol as if it's the safest thing. So
Mhm.
cool. It's just alcohol.
Unfortunately, it's not. Alcohol can be one of the most dangerous drugs out there. In fact, it is one of the most dangerous drugs out there. It costs our health system more than anything else that's consumable, um, apart from maybe cigarettes. So, alcohol is a bad idea. Any alcohol is bad for you. It can cause issues such as heart disease. It can cause liver disease. It can cause peripheral neuropathy. It can cause dementia to a certain extent. It can
When
cause
you
a lot
do
of
it over
issues.
a longer period of time.
Exactly. So it can be very, very problematic, and you can die from it, not only just from the issues that alcohol brings across, such as cancer, etc., liver cirrhosis, but also from the withdrawal itself of the alcohol. If it's severe enough, you can have a poor outcome and die.
Okay. It's just, I feel like all these diseases, let's say dementia, cancer,
Mhm.
even if someone was to be diagnosed with these diseases, you can't pinpoint that, okay, it's because of your alcohol that this is happening. It's like no direct relation, or your doctor can't tell you, okay, it's because of your alcohol that you're getting this disease.
You can, to a certain extent. We look at risk factors for diseases all the time. We can't definitively say that this is what caused it, but we look at risk factors. So for lung disease, for lung cancer, we can say that if you are a long-time smoker, it's likely related to your smoking.
Mhm.
So you can correlate the two together. It's not definitive, but absolutely. So we often do look at risk factors, and cancer can be secondary to alcohol use. So we do know that as well.
Okay. So, what is currently going on in Alberta that people outside wouldn't know? What is like the latest?
In terms of substance
In
use,
yeah.
I think the biggest thing that people are looking at Alberta around is the Compassion Prevention Act. So this is forced treatment of addiction, mandatory treatment of addiction against people's will. So involuntary treatment. This is something that's happening, that will be happening in Alberta very soon. It hasn't been implemented just yet. I think this is a very unique way to approach substance use. I don't know if it's the best way to approach substance use, but that's something that's happening in Alberta that we're not seeing anywhere else in other jurisdictions at this moment. And the government is saying that this Alberta model will be very unique. It'll be a one of a kind model. So it'll be interesting to see what happens.
So, the government is putting people into rehab without their consent. Is that?
Exactly. Or other treatment programs.
Or other treatment programs. Okay. What is bad about this?
Well, it what could be potentially bad about this is that it's not as good as voluntary treatment. When you look at studies comparing voluntary treatment to involuntary treatment, sometimes the results are equivocal, sometimes they're a bit worse. It depends. But we are worried about the fact that when we don't have enough capacity for voluntary treatment, why are we pursuing this path of forced treatment?
Mm.
Because there's tons of people who want to be into voluntary treatment and they're waiting on wait lists, but they can't get in. Um, the other big question is there another way out of this? Because like some people who don't want treatment may not benefit from treatment. We don't know who benefits from it and who doesn't. But what if we incentivize people into treatment? And I think that that's a better way to go. Is if we can incentivize people to get into treatment, I think that would be have better outcomes because it helps motivate people to get into treatment. And we know that motivation is a key factor in making sure that someone's successful with their treatment as well after the fact.
But if they are coming out with this plan, they should have an answer to this, right? Like, if there is not enough capacity for volunteer treatments, how are they going to do that? Like,
They
are they
haven't addressed
building
it
new
yet.
spaces?
I mean, they're trying to build more capacity for sure,
Okay.
but I mean, they're putting a lot of money into this forced treatment when it could be built into more voluntary treatment spaces.
Okay.
280 million to be exact.
That's a lot of money.
It is tons.
So I think this is the proper time to ask this question. But what are the gaps that you see between the policy makers and what is actually needed? Like you just pointed out that gap, right?
I mean, that's one gap, but I think, like, especially around homelessness, I think we're looking at the problem through the wrong lens. I think honestly, it's more of a brain injury issue, especially with those who are chronically homeless, like that 30 to 50% of the population, that we can appropriately address if we do our assessments of them appropriately, looking at their functional status, looking at whether or not they've had brain injury before, doing cognitive testing. I think
Physical
that's the way.
brain injury?
Sorry,
Physical brain injury?
physical brain injury.
Okay.
Yes, exactly.
Okay. So, look, people like you who work very closely, like probably on the ground, not as much, but you're involved. So, are your opinions, do you have a say in it?
I try to.
Okay.
Not always.
Okay.
Yeah.
The policies are just made by the government.
Policies are made, but also it's our responsibility and the government's responsibility too, to evaluate these policies and the impact of these policies. So that's a lot of my work as well, is to determine how these policies do impact our patients, the people who are involved in the patients' lives, their families, for example, other providers who are taking care of them. We want to know what the impacts of these policies are, and that's what a lot of my work is about.
How do you usually talk to the family of the affected members? Like, what is your advice? How do you talk to them?
Kind of what we talked about earlier. So it's that addiction isn't a personal choice or a personal failing. It is literally a medical disease, a diagnosis, a disease process that is hard to manage, and that they shouldn't think of it as a moral failing. There's a lot of stigma placed on them because they're using substances, and we shouldn't be providing that stigma. We should be supportive of them, trying to help them get better, not judge them.
Okay. You also work a lot and closely with refugees, LGBTQ communities, and even indigenous communities. So, are there any particular like barriers that they face?
A lot of the barriers are very similar. It's a lot of stigma, discrimination, lack of cultural supports and culture related supports, a lack of understanding of what their needs are, which can be very different from community to community, I should say. So it's, again, trying to understand what the needs are and facilitating those needs to best support them.
So, what role do you think communities or people in general could play or could do to help these people rather than just government doing it by themselves? Do you think there is any
Absolutely.
role?
I think as individuals, we can do so much to support this population. So first of all, being there for them. So being there with these individuals, taking care of them if they need, helping them access resources if they aren't able to access resources. And this can be something like seeing a person experiencing homelessness who's asking for directions to, let's say, a space where you can get a social worker and showing them the way to get there. This could mean carrying a naloxone kit with you. And if you see someone who's having an overdose event, reversing their overdose event. These are the things that us as a community can do, but we just have to be supportive of these individuals, help them get jobs, help them get treatment supports if they need it, not judge them, not show stigma, not discriminate against them. These are the simple things that as a community, that we can do for this population. One of my favorite stories, which I remember seeing on a YouTube video, funny enough, was this sort of analogy around what's called a rat park.
Mm-hmm.
So Rat Park is this story. It was a study done at Simon Fraser University in Vancouver, and in the 70s. And what they did was they put a rat in a box, and the box had two drips. It had a water drip and a heroin drip. And what they found was that the rat used the heroin drip until it died. Every rat that they put in these boxes used the heroin drip until they died. But then when they put these rats into what's called Rat Park, where there was other rats to play with, there was games, there was a wheel thing, there was food, and also these two drips, the heroin drip and the water drip, only 10% of them actually used the heroin drip. None of them died. The vast majority of them were using the water drip. So how does that translate to humans? So the story goes is that during the Vietnam War, we had tons of US soldiers in Vietnam who were having issues accessing tobacco. And so therefore they were smoking opium, which was much more abundant in Vietnam. And there was this fear that when they would come back to North America, that there would be an opioid crisis, quote unquote, because they were smoking so much opium. But what they found was that was not the case. Only about 10% of them continued to smoke an opium or opioid derivative. The rest were actually okay, and that's because when they returned to the United States, they were taken care of by their families. They were reintegrating with the community. Their community was supportive of them. They were seen as heroes by some for fighting in Vietnam. And so goes to show that if you have the right community supports, the right people around you, you can enter recovery, you can be better, you can do well.
Right. Beyond this story, do you also have a personal story like of a person who was addicted? Maybe they came back to living normal life, or how their story turned out to be,
Mhm.
how their regular life and now it led to addiction or something.
I mean, I don't know where to start. I hear these stories all the time. I think one of the individuals who I know personally has gone through this pathway and processes. His name is Earl Thiessen. He's now the executive director of what's called Oxford House here in Calgary, which is a rehabilitation facility, a bed-based treatment service. And so Earl had experienced homelessness in the past. He was on the streets. He had substance use concerns, and he was able to, through the appropriate supports, get to a place where he's now the executive director of this organization. And he's married now with kids. He's done well in his life, but he's a perfect example of recovery in action.
Yeah, it feels good to see these stories around where people
100%.
come out of
Yeah.
it. How do you get other doctors on board to, help you in this?
I don't know. It has to come internally. You have to really want to do this. I think just being excited about it, showing passion for it, sometimes gets other people excited as well for it. Understanding the problem, the complexity of the problem can often get people to want to be part of the solution as well. It's definitely not for everyone. But yeah, it's yeah, I don't really have an answer for that, to be honest with you. I wish I
Okay.
did.
Okay, but do you also think like educating people about substance abuse is important? And if yes, like how do you usually do it?
It is definitely important. It's through conversation. I like
Okay.
the one we had today. I think that the better we understand substance use concerns as a society, the better we'll treat our substance users.
Okay. But this work that you do is so heavy. How do you prevent burnout, or, how do you
Good
not
question.
bring that home?
Good question. I think just taking time for yourself, focusing on your wellness. These are all key, important, crucial things to do.
But with your busy schedule and like how much you have to be at the hospitals and here and there all the time, do you really take time out for your wellness?
I try to. I try to leave the country every now and then to go travel. That's my other big passion. So that's what I try to focus on.
Okay. But what is the hardest part of your work?
I think juggling multiple things at the same time. I've got it's not just clinical work, it's also research, it's also teaching, it's administrative work. It's a lot of work.
Right. And what is the rewarding part of your work?
It's kind of seeing people like Earl doing so much better with their lives, getting their lives back together, being happy. That's what's most important.
It feels like a rapid fire, but
Yeah.
is there, do you think your patients have taught you a lesson sometimes, like you get to learn from them?
Oh yeah, I mean the patients have teach me lessons all the time. They've also taught me how to manage some of these most complex issues. So the NORS program, for example, from an Alberta perspective, when I first engaged with it, came from a patient themselves. They
Mm.
teach me things all the time. So for example, when I was doing virtual care with someone, and he was in Grand Prairie, and he was using drugs alone. And I was like asking him if he had an naloxone kit, and I was hoping he wasn't using drugs alone. I was asking him about it, and he said that he kind of uses alone, he kind of doesn't. When I asked him, and when I was probing into it a bit more, I was like, what do you mean? And he said he was FaceTiming his buddy in Edmonton, that they're using drugs together. And I'm like, well, what happens if one of you overdoses? And he's like, well, we have each other's address. You can just call 911. Brilliant idea. Um, and so, yeah, that's what I mean. So the idea essentially came from some of the experience because they were already doing it, and we just scaled it up. So some of the best solutions for the most complex problems comes from the population that's experiencing it themselves.
That's true. And it totally makes sense.
Mhm.
Um, does technology play any part in this whole thing
In
for you, like in substance abuse, like rehab or the work that you do? or for patients?
I mean, it does. I mean, technology is all around us, right? I guess it's hard to say, but yeah, we use technology to treat patients. We use technology to understand what's going on with patients. We use technology to sort of synthesize complex data sets, helps us
Right.
understand the problem even more, whether it's through AI or some other machine learning mechanism. But yeah, that's technology is always a central to what we do.
Okay. But after this conversation, what is the one mindset shift that you want the listeners to go with or to
Mm.
learn? What is the one takeaway that you want them to?
I want people to be compassionate. I want them to be compassionate to those who are most vulnerable, those who are suffering, people who need support the most. I think through compassion we can do a lot of good things, and that's what I think we often lack is empathy and compassion in our communities.
Even generally, like we need more compassion, especially given the world we are living in today. But what are your goals about the work that you do? What do you really want to see in the future? What would success mean? Okay, that'll make you
Ooh,
happy.
I don't know. I think I have no idea, to be honest with you. Happiness is just so arbitrary, I find. But happiness is in your own hands, that's for sure.
Okay,
Um, yeah, I don't know what I want to see in terms of success, but I do want to make sure that people have the best health they can get.
that's nice.
Mhm.
But it was amazing talking to you, and I
Thanks for
got to
having me.
learn so many things about, substance abuse and how there is help available, and we just need to be humans
Mhm.
and, look around, be compassionate and kind. So thank you so much.
Thank
And,
you.
if any of the listeners want to get in touch with you or help you in any way, how can they reach out to you?
Just Google me. My email's out there. They'll find me.
Okay.
Uh,
Google your email or LinkedIn.
exactly. My LinkedIn as well.
Okay.
Okay.
That's how I reached out to you.
Yeah.
But thank you so much for this conversation.
Appreciate it as well. Thank you.
Yeah. And if you like this video, please don't forget to hit the like button, and I'll see you in the next one.